All right, I'm going to get started. Good evening, everybody. Welcome to South Sound Study Club. I'm Kevin Suzuki. We are Puget Sound Periodontics. Thank you all for being here. You guys have been really great about making this a packed house every time. It's my privilege tonight to recognize that Nobel BioCare has been a great partner to us all these years. Some of their team has actually come to spend a little bit of time with us and show off some of the technology, ways that they can support. I want to introduce Jeff Paulson first. He's the Senior Territory Manager. I'm going to let Jeff take it away for a minute here.
Yeah.
You want to start?
Absolutely.
Yep.
Thank you, Dr. Suzuki. I think I know most of you guys. Jeff with Nobel. I cover this area down here. We brought a couple different pieces of technology, obviously based on the subject that we're going over today, that we wanted to kind of assist and chat with. So we've got a couple different intraoral scanners over here. We now represent 3 different lines. I think of it kind of like a good, better, best as far as the IO scanners. The Dexys 3800, we have a new one from Dexys called the Imprevo. And then, of course, the Trios line, which I'm sure you guys are familiar with. The other scanner that you see over here on the right is called the iCam. This is something that is really picking up steam in the full arch space. So when these guys do a all-on-4, as we call it, you can do a scan with this scanner and be able to digitally print a temporary or provisional, sometimes, and deliver the same day. So with all of these technologies that we have, at least I'll speak to this side of the table, I'll let Will transition over there. But these sides over here are going to really help you be faster, if you guys aren't scanning already, faster from a restorative and impression perspective. And if we are doing larger cases, oftentimes a lot more accurate with the piece of equipment like the photogrammetry scanner. So, switching gears.
I was going to introduce also Mr. William Cassidy. He's the digital tech specialist for Nobel. He's here to offer some advice as well and information.
Yeah, appreciate it. I'll keep it short and sweet for the printing. So with printing, we have essentially 2 different units. If you're looking to just print and do your crowns, veneers, inlays, onlays, short, simple, quick and sweet, sub 10-minute prints, that'd be your Midas. That is a great unit. And if you want to print everything from Formula 1 race cars to dentures, hybrids, surgical guides, you name it, CT scans, this is going to be your workhorse right here. Essentially, I'm not here to just sell the product. I'm here to let you know about it. But my whole goal is to really just improve your workflows, so reduce chairside time, really make it work for you. I work with your office. I can do the training for you guys to make sure that it actually is a worthwhile investment. So we're not going to just drop it off your office and say, see you, good luck. We'll actually stay there and make sure that it works out for you guys and you guys are profitable. That's my goal. If you're not profitable, then I'm not doing my job right. So that's what we're here for. Thank you.
All right, thank you very much, guys. All right, and now it's my privilege to introduce our speaker. All of you probably have got a chance to get to know Dr. Juliana Shamoon a little bit better. She's been with us now. She's our most recent addition. Dr. Shamoon is originally from Chicago. She took care of our veterans for over 10 years there. She went to the Tufts University School of Medicine, Dental Medicine. She did the GPR at the Jesse Brown VA Hospital. She also did periodontics and dental implant surgery at the Zablocki VA Hospital. She was actually the GPR program director at Jesse Brown for a couple of years. Is that right?
Associate.
Yeah, she's an associate professor there. And then she's a diplomat at the American Board of Periodontology and Dental Implant Surgery. And so it's my privilege to introduce Dr. Shamoon.
Thank you, Kevin. Okay. All right, so today we'll be talking about how we, as dental surgeons, can leverage technology to create a very precise outcome at an interface that can be a little bit elusive. And that interface is the biorestorative area. And so this article right here just talks about the knowledge and use of digital technologies in periodontal practices. The majority of periodontal practices have a CBCT, they have an intraoral scanner, but nothing really beyond that. And that's fine, you can achieve a lot of efficiency, a lot of predictability with those 2 types of scanning modalities. But there are other technologies such as CAD/CAM, printing type of machines, milling machines, as well as robotic type of machines, and nowadays AI. Okay, so when we're talking about leveraging technology, what we're really trying to do is achieve an outcome that's fairly close to excellence, because if we're doing it analog, if we're doing it freehand, there's always a possibility for achieving a good outcome, but there might be little things that down the road might cause inflammation, down the road might turn into infection. So if we can minimize those types of outcomes by using technology that allows us to be precise, that allows us to be accurate, then we can achieve something close to excellence. Okay, and so how can we do that? If we are going to utilize technology, what can we utilize in terms of technology? We can utilize imaging, we can utilize digital planning, and if we put those two things together, then we can have guided execution. And so we can go from surgical success to restorative excellence. So if we can use a CBCT machine, if we can take an intraoral scan, fuse those two things together, then we can plan how we want to place our implant. We can plan what our abutment is going to look like. We can ultimately see what the restoration is going to look like. And those types of things, those types of knowing what the outcome is before you kind of see the patient is always nice to kind of have a type of outcome like that. And this particular picture is actually showing if they remove the tooth, what would the socket look like if the tooth is removed. And if you can do that, you can actually print out a guide that fits directly into the socket, about 2 to 3 millimeters. And so the deviation that we get sometimes at the apex or at the coronal aspect when we're using a guided, a static guide placing an implant, it'll lessen that type of deviation, not only depth-wise, but also in terms of the angle as well. So it's pretty cool stuff that they're coming out with. And that's more AI related though. Okay, so the learning objectives today will be, how can we identify current and emerging dental technologies that will allow us to create a biorestorative interface that is accurate, that is precise, and that allows long-term success without creating inflammation, without creating infection down the road. And then, of course, we'll explain the significance of that critical interface. Okay. So the biorestorative interface is defined as a critical transition zone where the biological tissues meet the restorative, this is a very sensitive, meet the restorative components of a dental implant or tooth restoration. And this particular biology was created because we placed an interim restoration in the area right after the implant was placed actually, and then the interim restoration was just a custom healing abutment. It wasn't necessarily an interim restoration with aesthetics, but you can see what you can achieve if you create a really good interim restoration there. Okay, so if there are potential weaknesses at that critical interface in dentistry, we need to bring in precision and accuracy using technology to help us achieve stable peri-implant soft tissues, support natural emergence profile and papilla formation, and ensure restorations that are functional, cleansable, and aesthetically pleasing, and then also reduces the risk of recession and long-term complications such as, again, inflammation and infection that could compromise aesthetics in the long run. Okay. Without leveraging technology, managing complex cases like this, or this, or this, can be really challenging. Okay. And so the current attention that we're giving to digital workflows rather than analog type of workflows is valid because digital workflows can create a restoratively driven, biologically compatible plan that can be designed in a short amount of time and can be executed with accuracy and precision. And so this is just an articulator, obviously, and this is just an article that I have in the later slides about how to use digital design using different angles of a person smiling at the 12 o'clock position, facial position, and then also at the occlusal view. Okay. So in this context, I think of workflow as a sequence of steps leading to a specific outcome, which in our world is ideally an excellent outcome. So there is photography, digital smile design software, scanning modalities such as CBCT and intraoral scanners, CAD/CAM, which is computer-aided design and computer-aided manufacturing, which I think has been the transformative thing in dentistry in the past however many years. But I think soon AI will be something that'll really trump CAD/CAM because it'll make things just automatic. And then also different type of technologies in terms of how we can place implants rather than just placing them freehand. And then again, emerging technologies, in particular AI technologies. Okay, so luckily we have the ability to design and execute excellence if we combine the modalities of photography with the concept of digital smile design, scanning modalities, and then being able to design what our prosthesis is going to look like, then eventually manufacture it. Okay. So computer-aided manufacturing, which is the CAM and CAD-CAM, allows us to print or mill physical objects. And in periodontal surgery, we mainly do this through 3D printing, and we're able to create restorations that are functional, aesthetic, and stable. Okay. So as the first step in perio-restorative workflow, high-quality photography can capture soft tissue architecture, which is critical for precise assessment of our perio tissues and predictable restorative outcomes. Okay. Building on that, if we were to look at this picture, the picture on the left actually represents the patient in temporaries, and the picture on the right represents the final restoration. What most likely occurred in this situation is when they were assessing the patient in her temporaries, they took a kind of a static smile and didn't actually see the smile in motion. So if we were actually to get a super great outcome, an excellent outcome, then the concept of dynamic photography, and in this particular article, they promote using iPhones to get dynamic photography, can allow you to get the smile in static, but also in motion, and that'll allow a better aesthetic outcome. Okay, and this is just this is just views at the 12 o'clock position, the facial position, and occlusal position. They have a software like digital smile design, and then they will mill out a prosthesis for the patient to wear. And while the patient is wearing it, they're going to be recorded smiling, talking, moving, so they can see how it really aligns with the patient's lips and facial harmony. Okay, and so this is the patient before, and this is the patient in temporaries, and that's, I think, a pretty good darn outcome. So, okay, these are my boys. Well, this is just one of my boys. This is Zach. He is very happy. He's also a scholar, and he likes to look at himself. So, yeah. Okay. So the next step in our workflow is data registration, and through data registration, we're going to use CBCT and intraoral scanning. If we were to rely solely on a CBCT for case planning, which only captures kind of bony anatomy, it leaves the restorative picture kind of incomplete. So generally, when I do implant planning, especially if it's for anterior cases, I like to do it guided, so I take a CBCT, I take an intraoral scan, and I use a fantastic lab, and that lab and myself go over what we want the emergence profile to be, where the gingival zenith is, where the tooth shape and whatnot, just so we can have the best outcome for our patients who need anterior aesthetic outcomes. So restoratively driven planning requires two data sets. It requires the bony anatomy. Sorry. It requires the bony anatomy, and it also requires the surface geometry of the soft tissue and the tooth anatomy. And if we take those two things, we can fuse them together, and then we can restoratively plan how we want to place the implant. And then if we plan it in a way where it is restoratively driven and we need additional adjunctive procedures such as bone augmentation or soft tissue grafting, we can do that after the fact. Okay, this I believe is a video. Tony, how do I press play? Do I just? That's all it is, okay. Okay, so this video is going to show how CBCT and intraoral scans are fused into a single digital model, and it creates a digital patient for us, essentially. And in software, this software is in particular, it's DTX Studio, which is also a Nobel Care product. We can also check the occlusion digitally before we're even planning the restoration. So that's a really nice feature of this particular software. And then the intraoral records and records the bite. The intraoral scanner, I'm sorry, is able to record the bite, and we're able to export that file, which is an STL file, and to a software like DTX, and then plan accordingly. Do I have to escape out of this, Tony? I gotta hit escape, right?
Yeah, just play it.
Oh, sorry, Tony. I don't know why I just said sorry, Tony, but anyway.
Let's now focus on implant workflow and the clinical steps that are generally required to plan an implant. When you want to merge your intraoral scan and your CBCT data, traditionally you must follow a corresponding point process, which looks like this. You place a point on your volume and find the same point on your intraoral scan. You do this for the right posterior, central, and left posterior areas. This match will only be as accurate as your point-based placement is. Some software require more points, but this is the process for manually registering your CBCT with your intraoral scan. Now, let's take a look at how DTX's Smart Simplicity handles this same data merge. With one click of a button, the whole process is completed, and an algorithm within our AI feature is actually looking at data points within each scan and matching those same points together. With this AI feature, we have a more accurate fusion of data between your intraoral scan and CBCT. Again, DTX Studio software is using AI or Smart Simplicity to eliminate tedious manual tasks, helping the office focus more on patient care.
Yeah. And whoever this lady is right. It is a tedious task to go through and manually fuse the CBCT to the intraoral scan. I used to spend many hours during my residency, day and night, fusing scans together, and sometimes it just wouldn't work. So the fact that there is an AI version of that is nice. Do any of you guys do this, have an intraoral scanner and a CBCT and kind of use this?
On implant workflow and the clinical.
Okay. This is a video that just kind of shows how to use the intraoral scanner to get a bite that you can transport into the DTX studio so that when you're planning a restoration, you can take into consideration the patient's bite as well.
DexSI is ScanFlow, how to scan the buccal bite tips and tricks recorded class. This recorded class is designed for clinical team members. It provides some tips and tricks that you can use to acquire a more efficient 3D model. By the end of this help session, you should be able to efficiently scan the buccal bite. In this session, we will explore how to take the bite registration. To start, first select the buccal bite registration option in the IS ScanFlow software. Next, take your scanner and press the mode button. Once it is activated, the indicator lights will turn on, signifying that both arches are selected and that we are ready to take a bite registration. Without touching the computer, all we need to take a bite registration is to have the patient establish occlusion by...
Sorry.
DexSI is ScanFlow, how to... Next, take your scanner and press the mode button. Once it is activated, the indicator lights will turn on, signifying that both arches are selected and that we are ready to take a bite registration. Without touching the computer, all we need to take a bite registration is to have the patient establish occlusion by closing their teeth and gently bite down. Once we are ready to take the bite, we need to make sure that the patient is keeping their jaw stable. When we are confident about the patient's positioning, we can place the tip on one side of the mouth and glide the scanner up and down along the buccal surface. The scanner will quickly capture the bite registration. To make sure that the bite is accurate, we can take another capture from another area. Again, without using the computer, I'm going to follow the same process.
Okay.
Once again, the scanner captured the bite very quickly. If the scanner encounters difficulties capturing the bite registration immediately, you can make a gentle sweeping motion to assist the process. If the bite registration remains elusive, maintain the same tip placement and gradually sweep from the top to the bottom, allowing the upper and lower dental arches to come together. We can do the same thing on the interior. Remember that for a partial arch, you should acquire at least 3 buccal bite images, 1 on the preparation, 1 mesial to the preparation, and 1 distal to the preparation. For a full arch, you should acquire at least 4 buccal bite images, 1 on each side of the mouth at the molars, and 1 on each side of the mouth at the canines. Once you've finished, you can check your captures in the occlusion gallery.
Okay. So, we use intraoral scanners pretty often at our office. We use it to fabricate S6 retainers. We use it to fabricate, well, not fabricate, but we send the STL file to a lab that'll help us make S6 retainers and also interim restorations. We'll also use intraoral scanners to kind of communicate if we're going to do guided surgery as well.
DEXA is scan flow, how to scan the buccal bite tips and transfer.
Okay, so after we do the intraoral scanning and it does the stitching, we can also use photogrammetry to precisely capture the 3D positions of scan bodies. And this will give us an exact digital map for planning and designing restorations. Intraoral scanning is excellent for single units, but if we're scanning multiple units, like Jeff was saying, if you're doing an all-on-X, you need something that doesn't accumulate so many errors, and intraoral scanning can accumulate errors. So photogrammetry is accurately records each implant's 3D position, especially if it's multiple units. Okay. So once the scan bodies and the implant positions are accurately mapped, either through intraoral scanning or photogrammetry, we can use that data to digitally design the prostheses that were in our CAD software, such as the DTX Studio software. In our peri world, the prosthesis that we're usually designing is a screw-retained interim restoration. And although it should be noted that we at PSP use the intraoral scanner to also design with our lab people that we use. Okay, so these photos represent some examples of how computer-aided designing can digitally plan, shape, and engineer an interim prosthesis or a surgical guide. These designs are brought to life through computer-aided manufacturing using 3D printing, such as the Sprint Ray over there. The particular printer that I have here is also the Sprint Ray right there. And these are just interim restorations. This is an S6 retainer, and this is a guide that we can print all through the 3D printer there. Okay. What's nice about 3D printers is that temporary shells can be printed in advance, or they can be printed immediately after the implant is placed. You just place a scan body, and you either take it with an intraoral scan or photogrammetry, and you can have an interim restoration ready to go day of implant placement, and that's kind of nice for anterior cases because patients leave feeling a little bit more human-like than if they were to leave with an S6. See if this is going to play or not. Yeah, okay.
Implant temp shell. And this temp shell will be demonstrated in how it's used after placing implants with more than 35 torque.
I'm actually going to skip out of this thing because it's going to take too long. I'm just going to forward through some stuff here.
Implant temp shell. Kind of move the tooth so it's going to look like guided surgery, and then use the temp shell to make the temporary. You must request a temp shell from the lab, so you're going to request what's called a lab design. And they're going to design the tooth, and this will be made into your temp shell. So as you can see here, I'm sending this off to the lab. Then the lab's going to receive the file through a digital network, which is secure and HIPAA compliant. And then they'll start to design where we want to place the temp shell. So they'll do a number of different, bring this out, tuck this in, and they can use tools to kind of paint and erase and kind of move
And you can do this at the
so-
lab, but you can also do this in-house as well if you have the appropriate software for it.
Get it all so that then the restorative doctor or the surgical doctor can have a look and see that this is what they really want. So once they'll do this, they'll use Nobel Design, send it, and then come back in. So they'll do what's called share. So when the file goes back to the doctor, then the doctor's going to have a look and make sure that it's okay. I can then have a look at this in my own Nobel Clinician software, and you can see, and I'm able to see it's a bit bulky, so I want them to cut it back a little bit, but I could do this chair side as well, but they may as well cut it back, and then I'll bring the tissue forward. So I'll say yes, it's a go. So then the lab will then start to put on the rests that are next to the adjacent teeth. So they'll select thickness of these rests and fabricate these rests so that it'll be supporting the temp shell in the position for pickup over top of the implant. So we know where the access is going to be in the lingual of this temp shell. We also will know the position of it, and it's going to be based on occlusion. Now what the lab will do is request an STL print file. And this print file or mill file will be used to fabricate the temp shell. The tissue is going to be predicting where the implant is going to be. This is how it's going to line up. So we can see here on the printed model that the temp shell is lined up using the adjacent teeth. So this is also so that we know where the implant is going to be. So once I start the case, I'll start by placing this in the patient's mouth and checking that it actually does fit. Here you can see that it does. The beauty of this technique is we're using a guided approach. So I'll still flap the tissue because I want to preserve the tissue and bring some of the lingual tissue out to the facial so I can make this an aesthetic outcome for the patient. We want to bulk this tissue out, so we may as well use this tissue that's going to be where the implant osteotomy is going to be.
So he's just going to go through the implant placement. We'll just move through that a little bit.
Patient. Once we put the third drill guide in, we're using. And as we check this implant, we can see that technique, and that will be one of my next videos. So I use some chlorhexidine. I want to make sure when I'm preparing things and drilling temporaries that I'm using chlorhexidine to rinse off microparticles or any bacteria or any kind of problems.
When they send you the interim restoration, it's not actually attached to the snap abutment. They purposely do that because the placement of the implant can be a little bit deviated from what was originally planned, so you'll have to attach those together the day of the surgery. But again, sometimes if you have a scan body and you have an intraoral scanner and a printer at the office, you can just put the scan body on, do it that way, and then have it printed that day.
It's not difficult, it's very predictable and very easy to do. Looking at the Nobel Clinician software, I'm able to prep the temp shell to make my access channel prior to even going near the patient. So you can see that right away I know that it's going to fit. And it's just so incredible. It was really very cool to work with and quite exciting, to be honest with you. And this is, I've been hand building temporaries. This is a very revolutionary way to make temporary and to make it so that it's going to be simple for many people to do. Now I placed some adhesive inside of the temp shell, so I'll be able to bond some flowable resin in here. If you did have the snap-on temporary cylinder, then you just put that on and put this over top and pick it up and then go right through, and that's very cool too. Here what I'm going to do is just put a little bit of temporary material, so a little bit of the flow. That point with the connective tissue is going to be 1.5 millimeters approximately. And then you have the acrylic is going to be up in the junctional epithelium area. So that this allows it to heal with the body, because the body does want to have something like the titanium interface or zirconia interface, but we want to have that titanium interface going through into the body so that we get great healing. Once that heals, then we can come back and start to make our final restoration. But you see, now we're creating emergence profile, and the emergence profile is going to be what controls how the soft tissue is going to look. So I can basically lift or, put it up or down, just like an airplane flap. I can lift the soft tissue that I'm going to move to the facial up and down to try to mimic the adjacent.
Okay. Okay.
Implant temp.
Okay. So after demonstrating the digital workflow for provisional restorations, we can use the same CAD/CAM concept for surgical CAD/CAM. So these days, a lot of attention is being drawn towards guides for crown lengthening, guides for augmentation, guides, of course, for implant placement, and also guides for soft tissue grafting. In particular, the guide is for how to harvest the CTG from the palate. And that's really helpful because sometimes we don't take enough graft, or we're working in an anatomical location such that we can create significant bleeding or nerve issues for the patient. So that guide is really nice to use. Okay. One surgical CAD/CAM approach is through bone augmentation or a mesh guide. And they have been looking at designing meshes through the CAD/CAM approach and then manufacturing the mesh. And then that way we have a very precise type of guide where we can design through CAD/CAM, we can design where our implants are going to be, and then from there design a mesh that is going to represent the crestal aspect of where we would like our bone to be. And so this is for the mandibular ridge here. You can see how deficient that is and how much they got out of there. And then this is also for the maxillary ridge. Again, super deficient. And if there's one thing that keeps periodontists humble, it's vertical augmentation. So to see that they're making some sort of progress in making this a little bit more streamlined, making this a little bit more precise, making it a little more accurate, these are exciting articles for us to read. This mesh is actually not, there's actually a picture and I should have put it on there. It literally just pops out. They put them into 2 screws. You take the screws off and the mesh will generally pop out. It's almost like it has Vaseline on it and it just kind of pops out. So as long as there isn't an undercut, it can generally pop out relatively easily.
So tissue doesn't get
like intertwined in it. It depends on the type of mesh, because sometimes that can become an issue where you kind of have to remove it. But in this particular article, they didn't seem to mention that that was a complication of when we remove the actual mesh, that was an issue for them. So it's kind of nice. And the bone graft material that they use here is just a combination of like xenograft and autogenous bone. A lot of these articles are done, or this research, they're done in Europe, and they don't use allograft the way that we do here in the States. So they'll always use a combination of xenograft and autogenous bone, and they get these really unbelievable outcomes. But an outcome like this, I've read a decent amount of research throughout my years, and I've never really seen something that is this precise, something that is this neat, and something that comes out with this type of outcome. It's almost unbelievable. I'm assuming they're going to come out with more research about this particular type of approach, but it's exciting to see. Okay. And this is the palatal guide that they do through CAD/CAM. This particular article is about moving the teeth via orthodontic treatment, but when they were moving the teeth via orthodontic treatment, they noticed that they're probably going to get some sort of dehiscence, and with the dehiscence, they'll probably get some sort of gingival recession. So preemptively, they want to do some gum grafting with the periodontist, but when we're dealing with such a large area with grafting like this, sometimes we don't take enough because we're concerned about where certain nerves are, where certain blood vessels are. So if we're able to take a CBCT, if we're able to take an intraoral scan of the mouth, fuse those together, and mark where these critical structures are, then we can avoid going into those structures, causing comorbidities, but still be able to get the amount of graft that we need to satisfy our orthodontic friends. And so this is just kind of a diagram showing the bony segmentation through CBCT, the intraoral scan, fusing those together, and then we also have measured out how much gum graft we need, and so we can do that through a virtual planning software. And then through that, once we design it, we can manufacture through a 3D printer the guide that we want. And so basically what we're doing here is this will be where we make our initial perpendicular incision, and then we're going to go apical this way to do kind of a trapdoor technique, which is basically we leave the epithelial tissue intact, but we will remove the connective tissue in that area. And we can be fairly comfortable while using this guide that we're not going to go into a sort of blood vessel that's going to create, for lack of a better word, a bloodbath, because that's what happens. Okay. And this is another article about using crown lengthening guides. Crown lengthening, a lot of it, quite honestly, is probably done freehand with periodontist. What we usually do is we'll take a CBCT scan. We'll have the patient put some cotton rolls underneath the lip so we can really evaluate where that CEJ is. And then from there, we can determine how much soft tissue we can remove and bone tissue we can remove without exposing the CEJ. Unless, however, there's a prosthetic plan to do restorative work, which in some cases, patients have a really short location of where the CEJ is. And so we'll expose the CEJ knowing that they'll need some sort of prosthetic rehabilitation afterward. But in this particular case, this wasn't freehand. This was a CAD-CAM guide that they fabricated for this particular patient. And you can see that she just has a ton of bone and probably some passive eruption. And so after going through certain diagnostic measures, they found that the best way to do this, or the best outcome that they want is this outcome, and they were able to plan that all digitally. And again, same thing, you take a CBCT scan, you take an intraoral scan, you fuse it, and you tell the system, according to her facial lips and facial structures, and sometimes you can do it through digital smile design software, you can get a guide that not only helps you dictate where you're going to remove the soft tissue, because that's going to be where her teeth are going to end up, but also the guide will tell you how much bone to remove in that area. And sometimes we remove the soft tissue and we think to ourselves, oh, this looks really beautiful, but then we get a little bit shy about how much bone we remove. And so the patient comes back after 3 to 4 weeks, and we think to ourselves, well, that came right back, because if you don't remove adequate bone, the tissue will kind of regrow to where the level of the bone is. So it's nice to have this type of guide because we'll have some sort of safety net in terms of, well, we can go up this much because we planned this much digitally. Again, I don't know many periodontists that are using this. This is relatively new. I do a lot of freehand with my aesthetic crown lengthening cases, but it's an interesting thing to kind of read about. And also, sometimes these things can be a little bit cumbersome, like to fit an actual blade in there might be a little bit difficult as well. Like you might need like a micro blade to go after these things. So you'd have to invest in that type of equipment, which I think we invest in that type of equipment at PSP, but we just haven't used this type of technology, I guess, for crown lengthening. This is my other boy. This is Ben. He is very happy after he takes his nap. And it's about 5 months at this point. Okay. This is an interesting article that talks about if you were to do implant placement via a guide, a static guide, implant placement via dynamic navigation, or implant placement through a robot, how much better would it be if you did it, if you compare that to freehand? And it's a decent amount better. I still think that you could do freehand and get a pretty good restorative outcome, but it's interesting to see the type of technologies that they have out there to help minimize deviation error from what was planned. not only in terms of like vertically from the crestal aspect to the apex, but also from an angle perspective. And what they found was that the robotic surgery created the least amount of deviation apically. It was like 0.5 millimeters. And also from an angle perspective, it was like less than 1 degree. But this robot is large and in charge and expensive. So I think it might be something that gets incorporated into the, the surgical world in the future. I don't know of very many who are doing it these days. I think the ones who do it end up on like a news channel of some sort saying, look at this dentist. So it's an interesting marketing thing to do. Okay, and this is a video about dynamic navigation. This is X-Guide. This is something that Nobel offers. And X-Guide basically uses scanners and markers and cameras in a plan that you've used, that you've already kind of formulated, and it tells you whether or not you're off in terms of angle, in terms of depth, and it's kind of cool to use. I used it once in residency, but I haven't used it since. Let me see if I can, there we go. Oh, hold on, I'm just seeing this. Sorry, guys. I gotta escape this again. So that is how you calibrate the system. It basically lets the cameras know where exactly the drill is in space. So you have to calibrate it before you do anything. And this is basically a screen that you're looking at that's going to show you where exactly your drill is in relation to the plan that you've created prior to placing the implant. And it shows you where you're at in terms of depth, your angle deviation. And they say it's like a GPS for your drill. And it just kind of shows you that this is where you planned it, this is where your implant's heading to. And so you're kind of hitting a target and a bullseye. And it's, it's just fun stuff to kind of think about that, you can do this type of stuff. But again, I think the result that they get when they do research about dynamic navigation versus a static guide versus freehand, it's a little bit better. Is it significantly better? Maybe in their research article they say it's significantly better, but it's like 0.5 millimeter or less than a millimeter different, So, and has anyone ever used this dynamic navigation before? Have you, Chad?
Yeah.
Oh, nice.
We had a demo in our office, and there was a couple minutes, and I got to use it. It's fun. It's literally like weird staring at a screen and like not looking at what you're doing.
Yeah. There's a bit of a learning curve. The Europeans love this type of stuff. They always lecture about this type of stuff. And the Americans always say, well, we can always do it freehand. So.
Is there an advantage over just a regular guide?
Like a static guide? It's a little bit better over a static guide because the deviation at the apex with a static guide, I believe, is like 1 to 1.5 millimeters, maybe a little bit more. With the dynamic navigation, it's about, if I read it correctly, I think it was like 0.5 to 0.7 millimeters. And the angle of deviation was a little bit less than a static guide as well. But overall, I don't think restoratively would make much of a difference. And I think, if I looked at the price correctly, I thought it was a lot more. It was like $39,000. I thought it was going to be like a $200,000 deal, but it wasn't too bad, I guess. But again, a learning curve with this thing. Okay, so there's that. And this is Yomi, okay? This is robotic surgery. This is like extremely precise, extremely accurate. I think it's like 0.2 to 0.5 millimeters of deviation from what the plan was. I've read about this thing. I'm not 100% sure how it works. I think these guys might explain it a little bit better than I would. Andrew, did you say that you've?
Yeah, it is essentially, you hold the, Ryan, you can correct me too. Okay. You essentially, all the wheel is connected to the robotic arm. It's kind of guiding.
And if you deviate from the plan, it resists you a little bit.
Yeah, it'll resist you so that you're in the right path of insertion. But
Yeah.
I don't know. The planning, it seemed, I don't know, to place a single implant.
Yeah.
So it's like lane assist for implants.
It is.
Yeah.
It is. If
Yeah.
you deviate, it's going to beep at you. And then, but if the patient moves, I don't know. I don't know.
These guys say your practice will fail without it, so, let's see.
And this might be like a $200,000. I don't know.
This, oh yeah, well, no big deal if your practice fails, right? Okay, so.
We have a state-of-the-art robotic arm that has got 6 degrees of freedom, that is always reading and getting information about where we are and what we're doing.
The software that controls how the robot moves with Yomi is programmed to go to exactly the right location to start the drilling procedure. And then as they're drilling, it constrains the robot so that it can only go up and down along that drill axis. And then as you're drilling, as you get to the bottom, it will stop you. The software controls how deep you can go, and it always goes to the bottom of the planned implant location.
We also have a tracking arm that is giving readings every time the patient moves.
This is kind of cool,
So
actually.
if the patient moves, Yomi follows the patient and it adjusts automatically to compensate for whatever movement that patient might have. And patients can move pretty quickly, Yomi will follow it.
The robotic system will physically guide them to get the exact position, angle, and depth that they planned preoperatively. And then the system also shows them visually on a screen so they get that confirmation that the surgery is going according to plan.
Yomi is going to be the future of the dental industry because we have all the technology that we have collected in all these years and we put it in the hands of the surgeon. That enables them to have better accuracy, it enables them to have more information and make better decisions.
Yeah, and in this, there was an article, this article right here, like I said, they stated that the robotic surgery outcome had the best outcome that was most accurate and most precise out of all the type of guided placements, basically. Which, I mean, I don't know how much research they have on robotic surgery, so I don't know how fair that is to say, but. Okay, so that was all kind of like CAD CAM stuff, where you kind of have to sit down in front of a computer, design it, and then kind of, print things out. Recently with AI, I think it's going to take a lot of the guesswork out from what we do as dentists in terms of diagnosing, in terms of saying this is how I want it to look. AI has its algorithms where they can kind of segment, where they can kind of analyze anatomy and kind of create the perfect kind of tooth. It can even draw where your nerves are. It can help you with kind of designing optimal flap designs. So AI is really, really exciting because I think it's going to make, it'll make our lives a little bit easier in terms of not spending so much time designing things when we're using a kind of a CAD CAM approach. So AI is going to be something, I think that's also going to revolutionize dentistry pretty significantly. I mean, we use AI in terms of, our notes at PSP. We have something called Nabla. It records our conversation. It creates an entire note for us, and it's fantastic. So I think Tom gave a lecture about that, and there's little nuances to it that you kind of have to figure out each day, but every time you get a little more used to it, it makes life a little bit easier, I think. So again, why AI matters, because of efficiency, accuracy, safety, predictability. You can also communicate with your patients, with our referrals, and the integration of it seems to be fairly seamless. Okay, and with Nobel, they have something called Smart Fusion, which basically you don't have to manually put marks on your intraoral scan and your CBCT scan. The software can bring those two together in seconds, which is amazing. And then also they have something called a smart setup, which will analyze the gingival zeniths and the soft tissue contours and the tooth anatomy of your intraoral scan and provide you with a fairly nice looking tooth that can not only help guide in the way that they're going to place the implant for you so that it's screw retained in an ideal world, but also if you wanted to print an interim restoration out, it could do that for you as well. And then the temp shell, of course, that video that I showed. And this is just a little video, I think.
We will use 2 AI features to get to implant ready faster with DTX Studio. First, we will merge our intraoral scan and CBCT. Next, we will create a virtual tooth.
And it was literally a click. I mean, it was so quick.
From the intraoral scan to create the tooth. There are no tooth libraries to choose from, so there will be no adjusting necessary once the restoration is proposed. Let's look at the proposed number 8. Creating an anterior tooth in a traditional 3D software rarely ever comes out as nicely the first time.
I think it could be a little nicer in my opinion, but you know.
Let's remove the virtual root that was proposed, and then we simply select Plan in the top menu bar and select our implant tab. Now we place our implant. We will scroll through our NPR views to make sure we are confident with our implant placement all around the site. With our Smart Simplicity, AI, and DTX, you can get to implant placement in less than 10 clicks once you open your software and start planning your case. DTX Studio's AI features.
I think what's really important to know about this type of technology is that in order to get to this really good, precise, excellent outcome, the data that we collect also has to be good and precise. Because if we don't collect it appropriately, then we have errors in each step. And so a lot of the stuff that we do, such as a CBCT, such as intraoral scanning, you know, it's done by our assistants. And I don't know about you guys, but having a tenured assistant is rare to come by these days. So you're constantly having somebody new taking this kind of data registration, and again, it's most likely not exactly the way that it should be taken. And so sometimes when we're looking at our outcomes and we think, gosh, you know, why is that not screw retained? Why did it come out from the facial? You know, it could be because these little errors kind of accumulated. And so there's a learning curve to it, which I think we as dentists can know how to kind of work through it. But if we're delegating these tasks to our assistants, and we're getting we're getting a new assistant every year, it can be hard to get this sort of excellent outcome that we're going after type of thing. And I think AI still has to kind of take a scan, still has to take a CBCT and an intraoral scan and bring it together. So it's kind of the same issue, but maybe one day they'll come out with something where we don't have to rely on our assistants to kind of give us this type of data registration. And we can be even more precise than what we are now. So, you know, technology is something I think on the daily at our practice we use a CBCT, we use an intraoral scanner. Sometimes we'll use a static guide for implant placement, but a lot of the times we're doing it through freehand, or we're just kind of making a little mock-up of a clear retainer and just kind of using it as a guide when we're placing our implants in. I think that in the future, we're going to have to embrace technology and bring a decent amount of it into our perio practices just to kind of keep up with the marketing demand of it all. But I also think that if we do incorporate it into our practices, I think it just makes our life easier, because I think with AI being just around the corner, it's something that I think can be certainly a marketing tool, but also just create better outcomes for our patients and maybe even reduce, you know, those weekend calls from our patients. So just because it's a bit of a better outcome for us. So anyone here really good with technology that has kind of comments on certain technologies that I didn't mention? All right, any questions at all? Any comments or statements? Okay. Thanks, Greg.
All right, thank you, everybody. I think William and Jeff, you guys are going to stick around a little bit to demo some of this technology. In case anybody wants to check out any of the pieces they have up here. Other than that, thank you all for coming. I think Tony's going to be sending out our next announcement.
Plan.
Yeah.
March. Yeah.
February, March. So we'll be sending everybody updates, and we'll send you the new schedule. So thanks for coming to the last meeting of this year. Wish you guys a great holiday, and feel free to talk to Jeff and William here. They're able to kind of answer questions and show off some of the technology a little bit longer. Thank you, everybody.
Please grab all the rest of the food too.